My name is Martin Miner. I am a clinical professor of family medicine and urology at the Warren Alpert School of Medicine at Brown University, co-director of the Men's Health Center at the Miriam Hospital. I'm here to talk to you today about new developments in testosterone and cardiovascular disease, specifically regarding the FDA and the intended to treat population and the T-trials summary. To understand the T-trials, we first have to discuss the labeling change from the FDA, which arrived in 2015 and noted that the intended population for testosterone treatment included hypogonadal men with specific disease conditions, or what was known as classical hypogonadism. Those men with Klinefelter's, pituitary injury, testicular tumors, or pituitary tumors. Product use data showed a very different real-world population of men being treated largely between the age of 40 and 60 years of age, thought to have adult onset hypogonadism, which was termed by the FDA to be age-related. However, we see that it was mostly comorbid-related hypogonadism, with the comorbidities being largely related to obesity, hypertension, dyslipidemia, and diabetes. The T-trials overview was published in the New England Journal of Medicine in 2016 and wanted to examine the effect of testosterone repletion on sexual function, vitality, and physical functions in older men older than 65 years of age, because this was thought to be the most vulnerable or perhaps highest risk group to treat. It was performed at 12 U.S. centers with 788 symptomatic men older than 65 years of age with too low total testosterone levels, less than 275 nanograms per deciliter. This study was of the highest quality, comparing a 1% testosterone gel and placebo. The conclusions include a statistically significant improvement of older men with testosterone in some parameters of sexual function and mood, no increase in cardiovascular events in either the testosterone or placebo arms in either the year of the trial or the year following the trial of observation. But remember, the study was not powered for safety. To look at the impact of testosterone in atherosclerosis, the investigators decided to look at coronary artery plaque volume, non-calcified coronary artery plaque volume, via CT angiogram at baseline and again at 12 months. Again, men were older than 65 years of age with what was only thought to be an age-related decline in testosterone. It involved 170 of the 788 men, but the men were not randomized completely blindly, but by minimization or a computerized technique to provide the best balance across groups on specific baseline characteristics. 138 men completed the study, 73 in the testosterone group, 65 in the placebo group, mean age 71.2 years, and the treatment group showed an increase in non-calcified plaque volume from 204 millimeter cubed to 232 millimeter cubed, or an estimated difference of 41 millimeter cubed. You could see the difference in baseline of the testosterone group, 204, versus the placebo group, 317, is quite significant, suggesting these might be two very different groups. These men had multiple comorbidities, and 50% had severe atherosclerosis as assessed by a CAC score of greater than 300, a mean ACC-AHA risk score of 24%, which is quite high. The majority of the plaque that was increased was thought to be an increase in the fibrous plaque volume, which is thought to be protective plaque, but its meaning is still not unknown. So, in conclusion, low testosterone is associated with increased atherosclerosis and MACE. Current evidence about the safety of TRT is hampered by the small ends of study, brief study follow-ups, and soft endpoints. There's no black box warning regarding MI and stroke. T trials lend soft support for T improving sexual function and mood, improved anemia and bone mineral density, no improvement in cognitive function or frailty or vitality. The increase in non-calcified plaque is of unknown significance. Thank you.